In our final session, we're going to have a talk about the ethics of research in developing countries. We heard yesterday from many of our speakers that they felt that their programs had to be absolutely ethically unassailable. And to speak with us about this important issue, I can't imagine someone who is more well qualified than Professor Brody, who is a member of the Department of Philosophy at Rice, where he is the Andrew Mello Professor of the Humanities. He also has a joint appointment at Baylor, where he is a professor of biomedical ethics and the director of the Center for Medical Ethics and Health Policy. He has served on a number of very important boards and commissions. He served on the Data Safety and Monitoring Board for the AIDS Clinical Trial Group. He served on the NIH's Recombinant DNA Advisory Committee, and he's also been a member of the Bioethics Advisory Board of the Howard Hughes Medical Institute. In 2001, he was elected to membership in the Institute of Medicine. So welcome, Professor Brody.
So I'm going to talk today in an introductory way about some of the issues related to research in communities. I've decided now to use the expression with limited resources, so I don't have to get into third world and all that sort of controversies. And what I'm going to do is draw upon practical examples, most of which I've been involved in, to illustrate some of these issues. So let me begin with the first example, and then I'll go to the slide related to that. I was asked about a decade ago by an industrial organization to chair the Ethics Advisory Board for a study, an epidemiological study, that they were planning in a country with limited but rapidly increasing resources. It's going to be a little difficult to present this example without breaking my agreements about confidentiality, but I am going to try to do it because it's such an important one. The industry in question produced many products, one of which was known to be quite toxic at rather high levels of exposure, and in fact, in most of the world, there had been mandated very low levels of maximum exposure. But this country had not had such standards until around the time when the study was going to begin. So it provided a unique opportunity to do a study in which you could look at people who had been exposed in the past when the standards weren't present, and they had been exposed at different levels, and then you could see the degrees of toxicities that had developed. It was, as it were, the last chance to get an answer to the question of what is the level of what type of toxicities without engaging in totally unethical exposure of people to totally inappropriate levels. So it was a last-ditch opportunity. And they recognized, of course, that there might be many ethical questions raised by such a study, hence the desire to, even in the planning stages, have an ethics advisory board. The question I raised before I accepted the job was, what standards would we be applying? That is, I actually think the whole world should simply agree with my ethical intuitions. However, benighted people seem not to do so. And so it looked like that would not be a good strategy. Perhaps it would be better to get some sort of standards that had been widely accepted. And we started looking for such standards. In particular, we wanted guidelines or standards that really addressed this question that we were concerned with, namely doing research in countries with much more limited resources. We did not find much help on this question in the Federal Common Rule, so we chose not to use that. We found a little, but not all that much help in the Declaration of Helsinki and its various manifestations over the years. But we did find one document that has come to have increasing significance in the discussion of these issues, and that's the standards that we chose, and these are the so-called CIOMS standards, the Council of International Organizations of Medical Societies, which is a non-governmental organization, and the official phrase is it's in official relation with the WHO. And if anyone knows exactly what being in official relation is, I would sure like to know. But it sounds good. Maybe they get a blessing annually from the WHO. I know they certainly don't get any money from them. Okay. They have issued guidelines for biomedical research involving human subjects. The first edition came out in 1982. A revised version was published in 1993, and the most recent version was published in 2002. And the reason why we chose to use these standards is that because in all of their guidelines, they gave sustained attention to our issue. In fact, it's the issue that really dominates in their guidelines. And this is not surprising, given the nature of the organization, given the relationship to the World Health Organization, that they would devote attention to this question of research in countries with more limited resources. What I'm going to do in this talk is introduce these issues by relation to the provisions of the 2002 CIOMS guidelines. I'm going to present these guidelines and then offer some evaluative comments, primarily by referring to a set of examples, some of which I came into contact with during that time I served on these various committees, and some of which, I have knowledge of, but not because I was involved in the decision making. Okay. I want to begin with, by the way the standards are articulated, there is a set of guidelines. They're very short, they're relatively brief, and then there are these very lengthy interpretive remarks. And if you want to know what they're really up to, there's no point in just reading the guidelines. You've got to read the interpretive remarks. And if occasionally you think the interpretive remarks contradict the text of the guidelines, then perhaps that's true. Okay. It's clear that there's a lot of compromise going on as they try to articulate these standards in relatively controversial issues. What I want to begin with is focusing on the guideline that gives a real sense of the basic CIOMS philosophy, a philosophy which I'm perfectly comfortable with, and it's crucially found in the second of the bullets up there, that when the research in question is being reviewed not merely by the researcher's IRB, but also, most importantly, by the relevant IRBs in the host country. It is extremely important that the ethical standards applied should be no less stringent than they would be for research carried out in the sponsoring country, which is just a fancy way of saying, if you want to cheat on research standards, we're not going to let you by going to less developed countries. That's really the basic philosophy, and that seems perfectly cool. Nevertheless, I have to tell you, even that has come under some criticism. On the grounds it is said, this is ethical imperialism. What right do we, developed and advanced countries have to impose our standards on these other countries that don't believe in individual rights or informed consent? After all, it's imperialistic for us. So, okay. On some other occasion, perhaps I'd like to discuss the issue of ethical imperialism, but I think I'll go on to the actual standards and simply say, if anyone believes in such notion as basic human rights that are international, then why should one suddenly be worried about that in this particular context? Okay. It's allergy season, for those of you who haven't noticed. I want to turn then to the first of the more controversial questions, and that has to do with the requirement of obtaining informed consent from any individual subject. And of course, CIOMS just reiterates that. That's one of those basic rights of research subjects that it is quite prepared to impose upon research wherever it is done. But then it has to confront the obvious question. What are you going to do about this requirement when you're doing research in cultures where the whole notion of approaching individuals to get their permission is not culturally meaningful? Either because you don't approach anyone to get their permission, or you do by approaching community leaders. And it's actually the community leader issue which is the one that has attracted the most attention. This happens, by the way, in quite advanced countries as well. Just think of doing research on indigenous populations in Canada, the United States, Australia, New Zealand, other such countries, where when they are organized into viable communities with community leadership, the notion that you would approach members to participate in the project without having discussed it first with the community leaders seems culturally inappropriate. So CIOMS thought it has come up with a great compromise. And initially it looks very plausible. In some cultures, an investigator may enter a community to conduct research or approach prospective subjects only after obtaining permission from a community leader. Such customs must be respected, but in no case may the permission of the community leader or another authority substitute for individual informed consent. In practical terms, according to CIOMS, there's a two-step process in such cases. In step one, what you do is get permission to conduct the study from community leaders with the understanding that, of course, no individual will be enrolled in the study until they have given their individual consent afterwards. So you both respect the culture and the universal rule, and all this seems like a splendid compromise until people began to think of what it really meant. Okay. Consider, for example, communities in which women are not well represented in the community leadership, and in which the community leadership may not be particularly interested in health issues related to women, and might well be uninterested in such research being carried on their community, in part because it may well reveal how bad the health problems are and how these matters have been neglected. This gives them the right to veto approaching women to participate in these studies within this community. In effect, what it has done, it is re-empower or strengthen the power of patriarchal societies. And that does not seem like a good idea. Interestingly enough, all this came out in the Canadian debate, because in Canada, the issue of doing research on indigenous populations is extremely important. And there are these three Canadian councils, and together they were putting forward these tripartite regulations, and they came up with something very similar to CIOMS, until the women who were involved in that discussion pointed out that this might not be such a good idea. And so, while this looks like an initially attractive compromise, one needs to be very sensitive to the possibility that this may actually be a mistake in certain cases. And then the issue of how to deal with those cases is one that CIOMS has not yet addressed. Fortunately, in the study that I was serving as the head of the Ethics Advisory Board, the community leadership, which was mostly the local political leaders, were perfectly happy to have this study done within their community for a variety of reasons, including that they were trying to get scientifically based standards for exposure, so they really wanted the data to be brought in, and they said, go ahead and see whom you can enroll, we're perfectly happy. So we didn't have to confront that question, but it is a question to be thought about, and the CIOMS standard on this matter is far from perfect. Another guideline is this matter of inducements to participate. There is in general great concern about the fact that we often enroll subjects in research because we pay them or we provide them various health-related benefits, and that may be excessively inducing and coercive because it's too good of a deal for them to refuse. CIOMS has accepted that view, and it has actually gone a step further. It has pointed out that after all, in many of these communities, a dollar goes, maybe a euro is what I should say now, goes a lot further than it does in the United States or Europe. So what we would think of as being a modest inducement is actually a very high inducement. So monetary and in-kind recompense must be evaluated in light of the traditions of the particular culture and population to determine whether, there's a misprint here, whether they constitute undue influence. This question actually did come up in our study, because we looked at what were being paid to research subjects in similar studies that were conducted in the United States and Europe. It didn't seem like a lot of money to us, but in that country, at that level of its development, it was considered a great deal of money. And so when we first looked at the CIOMS standards, it seemed the solution to that problem was pay them less. So it should not be an undue inducement. Now, I have to tell you that part of the way the discussion went in our study is based on the fact that I don't believe in this nonsense at all. See, here's what I really think. Undue inducements are what? Offers too good to refuse. You know what I like? Offers that are too good to refuse. And if anybody has such an offer, please make it to me. So why this should be... I'm here at Rice, because many years ago, a dean called me and made me an offer too good to refuse. So that was unethical on the part of the deal. He should have paid me less. No. So I don't believe in this undue inducement stuff at all. But here's the real problem. If you believe in it, and then you add the CIOMS standards, now we have an excuse for paying even less in these countries. What this really accomplishes is it makes research cheap. And that's quite beneficial for those doing the research, but I'm not sure why we have helped the research context in that setting. So we actually decided to disregard this standard and to pay the research subjects in the study we were conducting the same as they would have been paid had they been in such a study in the United States, which is where we had the best data. And we did enroll very quickly. And some of you might say, gee, undue inducement. And I say, no, rational people who saw it was a really good deal. And in fact, we made such a good deal available to them. And I have no hesitation about having thought that was okay. So that's a bit of a controversial issue, but I think one that deserves much further thought. I turn now to the two guidelines that have attracted particular attention. And in order to explain why they do, I want to begin with another example, and that is the example of maternal-fetal HIV transmission. Let me just remind you briefly about the history of this. 076 was a trial that the ACTG ran, which showed that a rather extensive and expensive regimen of AZT markedly reduced maternal-fetal transmission. I actually was on the committee that stopped that study at the first interim look, and we were all feeling real good that day because the thought was, we've just saved a large number of kids from getting HIV. And in fact, over the years now in countries like the United States, maternal-fetal transmission is an increasingly rare phenomenon unless the woman in question has not gotten prenatal care. Okay, so that's a great advance. At that time, there was no possibility that the 076 regimen was going to be available in many countries with limited resources. The regimen would cost vastly more than what the country was spending on all of healthcare for the year. And at that time, there were no United Nations programs, and President Bush hadn't wanted to allocate money, and Mr. Gates had not yet decided to make his major philanthropic efforts. And so looking at it, 076 looked great for the developed world, for the more affluent countries, but what were you going to do about maternal-fetal transmission in these other countries? And by the way, it's not just a monetary regimen. The 076 regimen is a complex regimen. It's a drug that has to be handled carefully, and the treatment goes on for months, both before and afterwards, and the thought that you were going to be able to pull that off in a country with a limited healthcare infrastructure was a non-starter. So that was the issue we were confronting. And not only we, but a large number of other groups. Very rapidly, a series of trials were run on regimens that were less expensive, easier to administer, and were viable candidates for being used in various countries with less resources, but in fact, everyone knew up front they weren't going to be as good. But, not as good is still better than what? Than nothing. Okay, so we all thought, this is a good idea. We're going to do research on these less expensive, more manageable regimens to see if they actually produce some positive results. Of course, it's better to produce some positive results than to just throw up your hands and do nothing. It also turned out, for good scientific reasons, that we needed to run those as placebo-controlled trials. Because if you compared them to the 076 regimen, what you would show is that they didn't work. They were not equivalent. They were inferior. Actually, it turns out that maybe that wasn't entirely right, but we don't have to worry about that. Up front, it certainly looked that way. And so a whole bunch of trials began, ranging all the way down to nevirapine, one dose as a regimen, and have actually showed tremendous possibilities for reducing maternal-fetal transmission much less expensively and with much less demands. So these were placebo-controlled trials when an active intervention that worked was known. And moreover, there was this thought that maybe we were doing research on these poor people to find a cheap regimen, which wasn't even going to necessarily be available to them. So there was much criticism, with perhaps some of the most extreme language used by Marcia Angel in an article in the New England Journal, which some of us took great exception to, but that's just a side remark. But in fact, that was not really the best example of the problem, because I've already argued that the research was done to be responsive to the health needs of the countries in question, and there was a really good reason for using the placebo-control groups. In fact, if you had not used the placebo-control groups, then one of the regimens would have been declared to be ineffective, even though it actually worked. Okay. So, I have to give you a second example, and then we have to apply the standards. And this is an example that I was not personally involved in, but it is really a marvelous example illustrating the issues, and it has to do with a drug called surfactant. That's with XIN, that the FDA has already issued an approvable letter, but has not yet approved because there have been some manufacturing issues and so forth, but the thought is they will approve it in the next few months. Surfactant is a new version of a surfactant. You'll keep in mind that this is a substance that needs to be present in the lung, and children suffering from respiratory distress syndrome, that's often due, in fact, almost always due to, especially with newborns, to do the fact that being premature, they have not yet developed enough surfactant. And by the time this drug came around, 4 drugs were already available of this class, but the thought was it would be good to have an additional drug, and there was even a suspicion that this additional drug might be better. Okay. And the original plan was to run trials in countries that had healthy health infrastructures and in which drugs were already available, but there was a problem from the company's perspective. If they were willing to run a trial to demonstrate superiority, that is, that this drug worked better than the other ones, the FDA would love them and it would have no major scientific and ethical issues, but unfortunately they weren't sure they had a superior product. So they were not, at the time, they were not too keen to run a superiority trial. Okay. So then they suggested, we'll run a trial in which half the patients get one of the conventional surfactants and half the patients get ours, and we will try to prove non-inferiority. Or alternatively, we'll try to prove equivalence. And unfortunately, there is a statistical issue associated with doing that in this particular case. Namely, if you look at all the trials that have been run of the other drugs, there's tremendous variability in response. And for those of you who've worked on statistical issues related to clinical trials, that's the kiss of death for in non-inferiority or even equivalence trials. So the company was in a bit of a bind. And the suggestion was made, and the company began to plan a research program that would take place in 4 Latin American countries, where in fact surfactant products were not widely available, where it was thought they were not likely in the near future to become widely available. It's not just the expense of the products. You have to have powerful capacities to put patients on respirators and to maintain them there. This requires big-time infrastructure. I mean, we do it and we take it, it's routine care at Texas Children or Herman's and so forth, but it's not routine care in much of the world, not just because of the expense of the drug. So the plan was to run a placebo-controlled trial, none of this non-inferiority stuff, and to run it in a country where the product was not going to be available if what? Even if the trial demonstrated that the new drug worked because of the expense and the infrastructure requirements. This is quite different than our example, because that meant, in effect, we were running the trial in the I want to be clear, because we were the good guys who were running the maternal transmission trial. They wanted to run this trial as a placebo-controlled trial, which they never could have run in the United States, to establish the worth of a drug that would then not be available in the community. It's the exact opposite of what we were up to in the maternal fetal transmission cases. Okay. And they ran immediately afoul of the CIOMS guidelines and also of a lot of people's ethical intuitions. So let me call your attention now to the two CIOMS standards that are relevant. Under guideline 10, the commentary says, in general, if there is good reason to believe that a product developed or knowledge generated is unlikely to be reasonably available to or applied to the benefit of the population of a proposed host country, after the conclusion, it is unethical to conduct the research in that country or community. In the maternal fetal transmission trials, it was quite realistic to expect. In fact, the whole point of those trials was to test regimens that could then be available and used, even with the lesser infrastructure. That's why everybody was so excited about nevirapine as a possibility, because its infrastructure needs are really quite modest compared to other regimens. But these guys were going to run a trial that was going to test in these Latin American countries something that they knew up front wasn't going to be available. Someone had suggested to them, maybe you could negotiate the price issue, and there had been some deliberations about how they would give a discount to these countries, but the discount didn't look all that impressive, and in any case it didn't address the other infrastructure needs that were going to be required for a surfactant product. In addition, the guideline 11 addresses the issue of placebo-controlled trials when established effective interventions exist, and the crucial thing that we need to note at the moment here is that plans have been agreed for making the intervention available in the host country once its effectiveness and so forth, and it's justified in regard to local healthcare needs. Okay, so that was one that, by the way, the irony of the whole story is when they actually finished their two trials in the United States and Europe, one of them was a superiority trial that demonstrated superiority. They should have been more confident in their own product. So it never became necessary to run this ethically quite dubious research. And so the FDA accepted with a pivotal trial that was a superiority, together with supportive data from a trial that was a non-inferiority trial. And as I said, it's been approvable, and it waits approval for some of the issues related to manufacturing quality and so forth. Let me give you perhaps one more example, and then I'll come to one or two final guidelines. One of the things that are very peculiar about treating AIDS patients is even if you give them antiretroviral drugs, so the CD4 count goes up, the viral load goes down, you don't really get a full reconstitution of the immune system. And this has been a sort of mystery, but there are various possible explanations. And the question is, can you do a bit more? So one of the trials was a trial that was proposed was to do an interleukin trial. in the thought that if you added that on into antiretroviral therapy, you might get a better reconstitution of the immune system. That was one that actually came to us. We approved that trial, but we knocked out of the trial 2 countries in which there were researchers who wanted to participate, where the countries didn't have antiretroviral therapy, forgetting about interleukin. In effect, they just wanted to be part of the international ethics network, but there was no way that the treatment, if effective, would have been established. And we said there's no reason why you should be doing that research in those countries. Okay, let me end by just talking about 2 other requirements. One is a requirement on sponsors to ensure that their products contribute effectively to national or local capacity to design and conduct biomedical research and to provide scientific review and monitoring of such research. The thought is that by the time the sponsor leaves the country, not merely should they not have done any harm in the course of that's a minimal requirement, but maybe they should have made a contribution as well, over and above the continued availability of the drugs. And one of the important contributions is to help build up the research infrastructure of the country. And in fact, going back now to the epidemiological study, we actually had all the lab work that was done in that country with a laboratory that was going to be left there for the use of the researchers in that country when our research was over. And we trained a large number of lab technicians and all types of other folks. So in effect, we gave them, as part of the quid pro quo for doing the research, a whole much more advanced research infrastructure. And finally, there is once more coming back to this question of ensuring that there is the availability of the relevant healthcare services and so forth. Let me end with one remark about this less standard. It's too weak. Let me explain what I mean by that. Very often, when you're going in to do research in the country, they've got a certain amount of infrastructure to support research, to support healthcare. You come in with your research. Typically, you wind up paying more. And you provide a more exciting opportunity and contact with the international research community, and the best and the brightest rush to be working for you. And what have you done to the infrastructure of the country's healthcare system? You have, for a period of time, drained off. And so it's not enough to ensure that healthcare services that are essential to the safe conduct of the research are available in the country. You have to make sure that you haven't made them less available, or you haven't weakened the capacity of the healthcare system of the country. And that's what we actually did in that epidemiological trial. Rather than using technicians that were already present, we trained a whole cadre of technicians and other sorts of technical people who were not part of that infrastructure and who, by the way, remained as a trained cadre afterwards. And so I think we went beyond the CIOMS standards in an appropriate fashion. Here's the take-home message. You can do research in countries with less resources. And it's often important to do that research, both for the countries and for other research reasons. You just have to be real careful about the design of the research, about the structural issues, the infrastructure issues, the availability afterwards issues, and they can be dealt with if there is the intention and the will to do that. One of the leading officials in the industrial organization said to me at the end, the recommendations of your committee have cost us a couple of $1 million. But it was a big study, so it wasn't that high a percentage. And he said, but it was worth it. So I thought he was going to say, because we went home and slept. He said, because this way we know we won't be on the New York Times front page. Well, I'll take it for whatever reason is possible. But I would have really preferred if he had said what many of his colleagues did say, for really what was, in a comparative sense, a modest investment. They could go home at the end of the day, having conducted the research and feeling comfortable that they had done so in an ethical fashion. Thank you all very much for your attention.
For questions?
Please.
New York Times about a month ago reported university professors being outraged with some of their IRBs, that the IRBs are becoming too conservative. And the example was given of a white researcher who wanted to interview black PhD candidates. What barriers did they have to face? The review board rejected that research thesis because of the fear that the black researchers might be harmed. What's your impression about the value of the boards?
Yeah, let me say, I don't want to comment on that specific example, primarily because it's the first time I heard about it. I must confess I get the Wall Street Journal in the morning rather than the New York Times because it's a lot cheaper. And it serves my needs since I only have about 5 minutes to read the paper anyway. So I didn't read about that one, and so be it. I actually have a great deal of concern about the IRBs, and I'll tell you why. Attention to details of rather modest significance and of process have taken up so much of the time of the IRBs that they don't really have the time to look carefully at the really bigger issues. I was on the rack at the time when all that stuff about Penn came out. Actually, that's not quite true. I came on the rack shortly afterwards. And one of the things to note was the Penn IRB had approved the protocol. So, but they were real tough on some of these paperwork requirements and so forth. But they missed the dangerousness of the vector, even though that was widely known in the research community. I'm a bit prejudiced because Dr. Bodetto heads our program, had been one of the major opponents of that vector for quite a while. But I think actually he was not the only one. How did that happen? Spend too much time on the less important stuff. You just can't handle the bigger stuff. And so it's not that I'm opposed to any one of them and saying, oh, that's a bit. I mean, there are a few actually. And if someone asks me, I'll be glad to give you an example of the one I hate the most. But it's not any one of them that's my problem. It's that if we build up too much of this stuff to pay attention to, there really isn't time to give the very serious consideration that needs to be given. So here's I like telling personal stories to illustrate. Here's an example that actually I was involved in. In the mid-'80s, a bunch of clinical trials were run on drugs like TPA to establish their effectiveness in treating patients who had just had MRs. I don't now want to get into the question of whether that's the best treatment today or not, but then it looked like a great advance. And the Baylor IRB was presented with such a protocol. And much attention was paid to the paperwork and the exact language of the consent form and all the usual stuff that occupies the IRB's attention. I just happen to have read, it's not just happen, I read the New England Journal each week to try to better understand this crazy world I participate in. I had just read Western Washington, which was not a study actually of intravenous use of thrombolytic agents, but of a similar type of administration, and the results were massively impressive. And I said, I'm not so sure I'm willing to vote for allowing these trials, which were going to go on all over the country, to take place at Baylor. Because I want to know, why are they placebo trials? And in fact, the Baylor IRB only approved the first stage of those trials, left it open, and in fact, at the end, the NIH never ran the planned trial for just that reason. But it was just an accident that I happened to be sitting there that day, and I happened to have read the New England Journal earlier in the week than I usually do. Otherwise, we would have approved it. What does that mean? That means that there's no time and resources in the IRB for someone to actually check the literature against what is being claimed in the protocols. I'd much rather spend the IRB's time on these important things. So if I had, remember I said to you, the world should follow my ethical intuition, but this is one I think they actually could be plausibly persuaded to follow. Namely, let's downplay a lot of those things so we can put the limited resources we have available into these big issues that really could have a substantial impact. So anyway, that's a heretical view, but one I think that's actually sort of reasonable. Please.
What are your views about community benefits? The HIV pandemic has introduced a new dynamics. The communities are asking for benefits.
Yep.
And this has not been addressed in any of the CIOMS guidelines.
Actually,
except that I think either CIOMS guideline 21 or 22 says that it's desirable.
Yeah, 20 and 21, I think it actually is where that stuff starts coming in a big-time way. So it's not just whether the intervention will be available, but what are you doing for the community in general? That's what we try to meet by putting in this business of building a laboratory that would remain there, training your research infrastructure, training technicians. We wanted to leave a benefit. Remember, because ours wasn't an interventional trial, so it wasn't like we could say the drug will be available afterwards. There was no drug. It was an epidemiological study. But we wanted to be able to say we're leaving a real benefit. And the real benefit was building the technical capacity that they would need to do a better work about monitoring environmental related issues. And so obviously since I pushed that one and got my colleagues to agree with it, obviously I do what? I agree with that, and that seems to me make a lot of sense. It's not, again, it's not just a question that we shouldn't harm the community in which we're doing the research. Why shouldn't we, as part of the quid pro quo of doing that research, actually produce a positive benefit that goes over the benefit of the individual subjects, that goes to the benefit of the community itself?
And when does your limitation ends in terms of commitment? Let's say you're doing a microbicide trial, an individual turns positive during the course of the trial, and the activists are saying you must treat that person for life.
Yeah. Okay. So now you introduce what is really an extremely important question, and that is this matter of balancing. And here's what I mean by that. On the one hand, we want to provide these benefits for the individual subjects and for the community. On the other hand, it's important that the research get done, and there are limited resources. So you've got to balance the one against the other. The second I hear the word lifetime, I start worrying about the balance, because push that one too hard, and the research may no longer be doable and affordable. Don't push it at all, you're not being fair to the community. And so as part of my general ethical approach, you just have to recognize that there are conflicting values and do the best you can to balance them in these sorts of cases. But it is a very important and a very difficult question. You know, it's also related to this issue, what does it mean it's reasonably available? One of those regimens that they were testing in the transmission trials, Thailand was one of the countries, they stopped the trial in the middle. Because the Queen of Thailand, God bless her, decided that she was going to make sure that all pregnant women got 076. And the Queen apparently has the capacity to get affluent individuals in the country to donate money to her charities. I'm not getting into the question of her techniques. And suddenly, the Royal Hospital in Bangkok had it available for everybody. And they pulled out of the trial at that time. And there was a famous article in the New England Journal which they explained why they pulled out, and that raises the larger question of, if you get someone to really care, whether it's Bill Gates or the Queen, does that change the dynamics of this business of reasonably available? And the answer is yes, and that makes those judgments even harder. Maybe we should stop at this point. Again, thank you all very much for your attention.
In our last panel, we're going to take a look at the challenges of establishing new initiatives that are focused on improving global health. And we have 4 panelists who are going to join us, who are, I think, at very interesting different stages of planning and implementing interventions. So I'm going to introduce our panelists. We have 4, and I'm going to start by introducing Dr. Ann Gillenwater, who is an associate professor in head and neck surgery at the UT-MD Anderson Cancer Center. And she's involved in the planning stages of an intervention to look at improving the detection of oral cancer in India. Our second panelist is Dr. Bob Parkerson, who is with the Baylor College of Medicine and has developed an intervention called Shoulder to Shoulder, which aims to improve health care in Santa Ana, Honduras. One of our third speakers will be Dr. Michelle Fallon, who is a professor of gynecologic oncology at the UT-MD Anderson Cancer Center and has been developing and implementing an intervention to stop cervical cancer in the country of Nigeria. But our first speaker is going to give, I think, a very interesting historical perspective about taking an intervention from early research stages to worldwide implementation. And that is Professor Stanley Schultz, who is the Wayne Hightower Distinguished Professor of Medical Sciences at the UT Medical School, Houston. Dr. Schultz was involved in some of the very early research that established the scientific foundation of oral rehydration therapy, which Dr. Glass talked about in the opening talk of this conference. So we're delighted that he could be here with us this morning to begin this panel by talking about the challenges to the global adoption of oral rehydration therapy. So Dr. Schultz will lead off the panel.
Thank you very much, Rebecca. I'm truly delighted to be here and relate to you some of my own experiences with the adoption of oral rehydration therapy and the problems that I had encountered. Now, why is this an interesting topic? Now, oral rehydration therapy, which is used for the treatment of secretory diarrheas, is a very instructive reductionist model when we want to consider the challenges to technology transfer, and the reason is there is no technology to speak of. All of the obstacles are in the transfer or implementation. Just to show you that's the technology, this solution, which has been referred to as the elixir of life, is simply a household mixture of sugar, table salt, and boiled water. Now, it comes in some fancier guises, and I can show you an I mean, there is the so-called village recipe that was introduced in 1971. I hope that you have been about that. And that is the package, now in a number of languages, distributed at the rate of 750,000 packages a year worldwide. And there, I'm sure if you know Gatorade, which actually preceded the UNICEF. It was introduced in the Cotton Bowl in 1967, and had the Gators not won the Cotton Bowl, we might not have heard about Gatorade. And then, of course, we have Pedialyte, which many homes know all about. These are all fundamentally the same, the essential ingredient being sugar and salt. Now, I thought I'd take you on a brief history of ORT in the early 60s. My laboratory demonstrated that there was a very tight obligatory coupling between sodium absorption and the absorption of sugars and amino acids, so that the presence of sugar or amino acid in the gut would accelerate sodium absorption and with it water. And a few years later, we demonstrated the efficacy of this approach in an animal model, the rabbit, and we used a purified toxin that was sent to me by Ralph Finkelstein, who isolated it in Thailand just that very same year. Then, in '68, Norma Sean showed in a controlled study that it worked in man, and a couple of years later, Dave Nalen and Richard Cash showed that if you add amino acids to the sugar, you get even a better result. And at this point, all of the necessary controlled studies were done. The basic science was known, animal studies and human studies. Then, the real turning point occurred in 1971, and this had nothing to do with thinking. In 1971, the War of Liberation in Bangladesh took place, and 6 million refugees fled from what was East Pakistan into India. And they lived in squalid camps, and about 4,000 or more came down with cholera. And then what happened is they ran out of IV solutions, which was the traditional way of treatment. Just ran out of it because these patients might need 60 or 70 liters of IV replacement. So they said, hey, let's try that oral stuff. And they make these huge vats of salt and sugar and water. And they told people, drink as much as you can. And they did. And the mortality rate fell from 18% on IV to 3% orally. And I might add that the cost of that whole thing, 50,000 liters of ORD, was $750. So, it took a long time, between 71 and 75, for the World Health Organization to finally coming about to adopt a single formula, which I showed you in an earlier slide, for all ages and all etiologies of diarrhea. And we were very upset about the delay, my colleagues and I, because the estimate is it caused 10 million lives because of debate, and another instance that I'll show you about in a moment. And so the question I want to address very briefly in my remaining time is, what is it that limits the global use of oral rehydration therapy? Why are millions still dying annually from dehydration? After all, unlike the technology you saw in this conference, it is cheap. The most expensive item is sugar. It does not require high-tech biotechnology. It does not involve vaccines. It does not involve antivirals. It shouldn't even involve a drum. And it certainly doesn't involve a refrigerator. And so what's the problem? Well, early on, there was concern and legitimate skepticism whether such a simple thing could work in severely dehydrated patients, and I'll show you that it does. And then none of this was helped by some people call it ill-conceived, I call it idiotic, a study that was done in the Philippines, where if you look at it hard, it was essentially giving a laxative to someone with diarrhea, and you don't want to give a laxative to someone with diarrhea, and that set back the whole enthusiasm for rehydration therapy. And then there has always been an emotional division between the so-called guys in the field and the white-coated scientists at the bench. It's sort of a macho thing. I've spoken to people, and they say, oh, Stanley, you don't know what's going on out there. Well, I guess I don't. Now, one of the problems today Well, first let me say that over the past 3 decades, the efficacy of oral rehydration therapy has been universally demonstrated in hundreds of outbreaks of diarrheal diseases of whatever etiology worldwide, involving millions. There's no question about this any longer. There's absolutely no doubt about its efficacy. Here is an illustration from 1971 from the war of Bangladesh, and we see a young lady on admission with the typical characteristics of dehydration: sunken, deep, dark eyes, semi-closed, almost in delirium, and the loss of elasticity in the skin. You see, if you pinch up the skin, it dented and didn't relax. Here is a mother giving her oral rehydration therapy. 4 hours later, she looked like a different child. And 18 hours later, she's walking around. And this is not a untypical example. There are hundreds and hundreds of pictures like this. So it does work even in very sick children, and the reason is physiological. The dehydration stimulates thirst, and anyone who's ever seen people terribly dehydrated or in shock know however pain they may be in, the thing they complain about is I'm thirsty. And wards of people with cholera are thrashing around for something to drink. So if you give them something to drink, they drink avidly and satiate themselves, and their own body tells them when they've had enough. That's not like an IV solution where you have no control and can be overhydrated. Here is another piece of data that's rather striking. It is estimated that oral rehydration therapy over the 20-year period between 1980 and 2000 saved or contributed to saving over 30 million or around 30 million lives of children between 28 weeks really and 4 years. So absolutely no question about it. So what are the challenges today? First of all, throughout history, the medical profession has had difficulty shaking loose from the grip of tradition, and IV therapy was the tradition at the time. While also, as we know, physicians and many patients often equate the best treatment with the most expensive treatment, the most complex treatment, and they all know, what do you mean giving me this Gatorade to drink when I'm so sick? And then, as you know, preventive care and over-the-counter preventatives and treatments are underinsured in this country and in many industrialized nations. Insurers will much more readily reimburse $3,000 per patient, and that is the average value for rehydrating a person in a hospital with intravenous fluids, but will not reimburse $20 for outpatient oral rehydration. And indeed, a study done in 2003-2004, only 24 states in the United States permitted indigent people with medical assisted cards to purchase solutions like Pedialyte and be reimbursed. So what happens? These people allow, because of it, $20 is a lot of money to many people, that the children get increasingly dehydrated, and finally they rush them to the emergency room, and instead of $20, it's $3,000 or $4,000. And then, regrettably, I learned during a recent trip to Bangkok, there is a resistance on the part of local physicians to transfer the authority for medical care to non-physicians, and in many areas, particularly mothers. Let me summarize that I think that the challenges confronting the expanded use of ORD do not involve overcoming difficult technological problems. They do involve changing attitudes, changing behavior, changing public policy and societal commitment. Healthcare dispensers, public policy makers, parents, etc. must be educated about the efficacy and safety of ORD and start giving it the moment and that shouldn't be emphasized too much, the very moment that dehydration is suspected or is evident. And finally, provision must be made for the availability and distribution to all, regardless of their socio-economic status. To conclude, in 2006, the innovation cycle was a report of the World Health Organization Commission on Intellectual Property Rights, Innovation, and Public Health, and it's available on the web. And what they argued is for the 4 Ds: discovery and proof of efficacies, development, delivery, and distribution. I would like to add 2 additional items. The first is awareness that there are many problems in this age of specialization, that the worker at the bench has no concept that they even exist, and that they may be working on something themselves that could be applied to the benefit of mankind. And the final one is education, compliance, and behavioral modification. We have many examples of instances where education, compliance, and behavioral modification is key to the implementation of already proven therapies. And with that, I thank you very much for your attention.
Well, that was an incredible talk, and it's humbling to have to speak after you, Dr. Schultz. My name is Ann Gillenwater, and I'm an associate professor of head and neck surgery at MD Anderson. And I'm the novice on the panel, so I'm going to give you my thoughts as I was trying to put together a trial. We're hoping to get a trial started within the next few months in India on oral screening. And so these are sort of the thought processes I went through when creating a clinical trial in a third world country or developing country or even any other country. I think the first thing you need is motivation. You need inspiration or a good idea. It's important to pick out good co-investigators and collaborators. Then you got to find money. That's a really important one. You have to have support of your institution and your family too. You got to figure out how to get around red tape, work out some logistics, and then you have to find some time. And so I'll go over these with some examples a little bit. My motivation is oral cancer. Now, it's not the most common, and many people in this country have never heard of it. There's 30,000 cases in the United States each year. The 5-year survival is poor. It's very bad. It's worse even than cervical. But and the other problem is that the treatment for patients with oral cancer as well as head and neck cancer causes severe morbidity. It's not a real big priority in the United States, but it's a huge issue in developing countries. And it's definitely in the top 10, and some people say that it's number 6 in ranking of the most common cancers worldwide. And in particular, most of these cancers are in developing countries. And one area in particular that I'm going to focus on is in India. It's the most common cancer in men in India and the 3rd most common in women. Now, most patients present with very advanced lesions, and when they're advanced like this, the therapy is very morbid. It's very hard on patients and their family. It's expensive, and it's not successful. So what we think is that early detection is the best way to improve outcomes. And I would also argue for my disease site in that it's a very easy area to do screening trials. It's easily accessible. People don't even have to take their clothes off, so you don't need a lot of fancy rooms and instruments necessarily. There's a well-defined progression model, and what I mean by this is it just doesn't happen overnight. It takes a while to develop, and there are some clinically evident stages that you can recognize as it progresses. But one of the big problems in oral cancer screening is today in this country, as in all countries really, the major way that we screen for oral cancer is just by physical examination. And frankly, I use a headlight, but some people just use a pen light and they look in the mouth and they see if they see any changes that look like cancer. And the problem is this is really dependent on the experience of the person who's doing the examining. And I'm supposedly an expert, and I can tell you right now that I have difficulty telling sometimes when something's a premalignant lesion, when it's a cancer, when it's going to become a cancer, because they look a lot like other benign lesions. So my inspiration, not mine, but our inspiration, is that we need new technologies to come up with better screening to avoid that problem of having to train everyone in the world to recognize cancer in the oral cavity. So I've been working with Dr. Rebecca Richards-Cordum and others to develop optical technologies. And I'm sure you've heard already, the idea, oh you haven't, the idea behind this is that our eyes may not be optimally manufactured to pick up the signs of oral cancer using just normal white light. And if we use different colors of light, then it will be able to allow us to see and also diagnose cancer. And particularly if you shine light on the tissue and evaluate the way the light is scattered or it induces fluorescence, and then measure the amount of this fluorescent light or reflectance light, you can pick up differences between normal tissue and abnormal tissue. And you can do this with an instrument like a probe, and that will give you a spectra, and you can come up with a computer algorithm. Our idea is to get a box that we can put into a dentist office or a public health clinic or even on the road, and you put the little probe on the area that you see, and then the light shines green. Oh, that's good. Red, bad, yellow, I don't know, maybe we better have it investigated. So this is sort of our inspiration and our big idea. The other big idea was, of course, we want to try and do this in India because it's a huge problem in India and there's a lot of people there. And so I think we can combine the two to really test out devices to see if they have any efficacy. My next little dot was to try and find co-investigators who were interested in this kind of an approach. And I'm very fortunate to work with Dr. Cordum here at Rice, and she's interested, so that was great. But we also needed to find somebody interested in in India. And through MD Anderson, which has been setting up sort of sister institution programs in different countries, they're also interested in setting up in India, and we were fortunate to have some backing from the Indo-American Houston Chamber of Commerce, or some iteration of that, to try to set up closer ties between the Tata Memorial Hospital in Mumbai, India, and MD Anderson. And through that, I was able to contact a physician at Tata who's also a head and neck surgeon who has the same motivation and inspiration. His passion is to try and develop new ways to screen and evaluate for oral cancer. So when picking a co-investigator, I think you need to find somebody who's got your same motivation and your same passion. You also want to find somebody who knows what they're doing and has the proper expertise, or you're going to be wasting your time in your institutions. And you also have to have somebody who has the resources, someone who has access to patients, who has access to like I'm thinking of doing a clinical trial, so I need someone who can help me set up clinical trials that are there. So these are some of the things I was looking at. Now, one of the big stumbling blocks for me was, where am I going to get money to pay for this? Who's going to help me get this done? And I don't have any great answers, but we're working on it. The first one, we went to look at the government. Can we get a grant? Because we're researchers, and that's what we're used to doing, is getting a grant to pay for research. So we looked and looked and looked, and some of the areas that we've applied to the Fogarty International Research Collaboration, and we're hoping to get money from them. But you also look for student training grants to train graduate students and postdocs who might be willing to go do this clinical trial with you. And it also be noted that I have my co-investor, Dr. Chakravarti in India, is doing the same thing with his government. So they're applying for grants through the Indian government to get money to pay for the trials. And there's also a lot of government initiatives just for clinical trials. So those are the other places we looked. For private funding, again, we're going to hit up the Houston Indo-American Chamber of Commerce for some more money, hopefully. Other places like the Gates Foundation, I wish I could get them more interested in cancer, but we'll work on them. There's a lot of cancer foundations, American Cancer Society. These are places that we've been trying to get money from. Corporations, I'm going to hit Continental up for airline tickets to and from India, and that'll take a big chunk, and I think we may be successful there. Looking for big, I think a great idea that Dr. Fohn had was look for big companies that have an interest in that community, whether it's GE, Exxon, somebody who's doing a lot of business there would like to help get some good PR. And then finally looking at the institution, see if the institution will help you pay for that with any institutional grants. It's also very important to get institutional support. I'd say if your institution isn't happy about the idea or isn't supportive, it's not going to happen, because they're going to have that, and your chairman, they're going to have to give you the support to allow you the time, money, name recognition, whatever you need to set up these trials. Another big one is regulations. I know we already heard this morning a very eloquent talk about the ethical issues with the regulations and the IRB. This is something you have to work out, IRB approval at your institution, and every single institution you're going to be doing it's going to be involved in the trial. So we have to get the IRBs approved in India and here. They don't always conform, so that's an issue. Consent forms are a big issue because, what we think is a proper consent form may not necessarily be what they think is a proper consent form, and, whose patients are they anyway? And you have to remember you have to translate all these too, so that they can't just be in English. It's also important you have to follow the guidelines of any of these people that gave you money. So they may have different guidelines about the trial that you have to be aware of. Institutional guidelines, your own institution has to back you, so you have to get those guidelines done. And then there's a lot of other stuff like visas and medical licenses. I know for our trial we develop an instrument, and we do look at whether it's cancer or not, and we try to verify it with a biopsy. Well, there's a regulation in India, they don't want their tissue leaving the country. Okay? So we can't take the biopsies and bring them back here to be evaluated. You have to be aware of these regulations, and luckily, and you go back to your co-investigators and their resources, they've got good resources there to do histology and pathology and to evaluate molecular profiles there. So just another example of the red tape you need to be aware of, and I'm sure I'm going to find out a lot more about that. Logistics. It's important, there's a lot of things to work out and plan ahead, and I'm sure I've forgotten a lot of stuff, but, you need personnel, so you need someone who's going to go over there and people who are going to conduct the clinical trial in the location that you're going to do the trial. You need to figure out the timing. You have to work around obligations here at your institute, what your patients or other colleagues are expecting from you, as well as your family. You have to work out in the schedule at the projected site. Maybe they've got a big deal coming, so they can't do it only on certain months. for us, we're worried about the weather. We don't really want to be there during the monsoon. So a lot of different issues with the timing. Students, when they need to get it done for their PhD, so there's a lot of timing issues. Travel, you want to get visas, immunizations, figure out how you're going to get there, who's going to pay for it, and then once you're there, who's going to, where you're going to stay. And then equipment. And equipment is a big one for us because we're trying to test new technologies. And so we've spent a lot of time trying to come up with I call it a gizmo, but it's a device that's portable, that's cheap, and that's indestructible. Because we want some, and we also want something that's not going to require steady electricity, because the electricity doesn't always stay right online there. So we want something that's battery powered. And we also want something that's going to work where we're doing it. We don't want something that's only going to work in the United States because, what's the point? So we're trying to develop equipment that we can bring there, leave there, and have it work there. And then finally, time. I first went to Mumbai to sort of start talking about these collaborations in 2003, and it's 2007, and we're just now thinking we're going to get going. So it takes a lot of time, and it takes a lot of preparation. And I don't have anything on my CV to say, well, I spent a lot of time trying to make a trial in India. So these are issues that you need to think about. And I'm sure I'm going to learn a lot more. So I thank you for letting me share my thoughts.
Well, good afternoon now. I'm Bob Parkinson from Baylor College of Medicine, and I feel honored to get to be with your group this morning. Thank you everybody for inviting me. Now, how do I work this to change the slide? I'm pleased this morning to get to talk to you about Baylor Shoulder to Shoulder Foundation. And this is there we go. This is an effort that's been going on now about 5 years that I've been able to be involved with. But we really are shifting gears now to a more grassroots, community level sort of program. So why are these people smiling? Well, mostly this is something to smile about. It's a great program. Where we get to put into place things like Dr. Schultz has brought from the bench to the field every day with ORT and other applied medical technologies. It brings public health and curative health to these folks who are truly under-resourced. This little area is on the border of El Salvador and Honduras. And it's about a 9-hour bus trip out in the country. But there are lots of challenges as well. About twice a year, we take a group of medical students and residents and faculty down to go to this area. We are so fortunate now to have other groups like Dr. Richard Squirtum's group and a group from UT Dental Branch coming up and the University of Houston as well joining us. But twice a year we go down for a 2-week period of time to do public health projects and curative medicine in this rural area. It's a nice continental flight, first world sort of experience down to Tegucigalpa, and then it's a 9-hour bus ride out in the country. The roads slowly transition from being paved to being gravel to being, potholes interrupted by bumps and that sort of thing. But it's beautiful, and the people are lovely. The nearest larger town to where we work is Colomancagua. This is Colomancagua. You can see that there are electricity, there are electrical lines, telephone lines, paved roads, good leadership in this town. So the bus can get through to Colomancagua, but then after that, the roads get to be the potholes sort of variety, and we have to get in the back of pickup trucks to get to our final destination of Santa Ana. Santa Ana is about a town of about 700 people, but the total group of people that we serve is about 10,000 folks in about 14 villages. These are villages that are within 3 or 4 hours walking distance to this little town. And this is Santa Ana. This is the town square, typical town square, Catholic church, a TWD, as we say, a third world dog. He's actually pretty first world. He's got, if you notice on his left front leg, he's got a bandage, so somebody's really taking care of that guy. So what do we do in Santa Ana? Well, we have school health fairs, just trying to help school children from these various villages to learn about basic health and public health issues. Big fun. Lots of fun for everybody, for the kids, for their teachers, for our medical students, and so forth. We weigh babies and measure babies and try to intervene in the unfortunate prevalence of stunting and micronutrient deficiency in the whole country, in the rural areas, but in this area too. This is an early childhood feeding program for kids coming off the breast. This is a very small program. It's not reaching the people it needs to reach and so forth. Maybe 30 to 40 kids involved with that. Larger numbers of children involved with a school lunch program. These are their mothers preparing that, but we help support that. We do lots of CME, continuing medical education, for nurse midwives. All the deliveries in the rural areas are done by traditional birth attendants. And these are the most wonderful women. You know, you can't imagine what a good job they do. They have no real formal education, but they're trained by other midwives, and they feel a real calling to do what they do, and they do it well. And we try to augment their work by education. This is a larger CME event for midwives we had in the whole region. And we see a lot of sick people, up to about 1,000 patients in 7 working days, which for Baylor students is a pretty heavy clinical load. This is a great experience. They see each patient primarily and then come precept with a faculty preceptor. Mostly what we see is just primary health care sort of problems, respiratory illness, GI illness, GYN, musculoskeletal trauma, dermatologic stuff. But occasionally we do see more severe illness like kwashiorkor in this young child with a bad social situation, a more severe and life-threatening form of protein calorie malnutrition. And things are more advanced when we see them. People don't have access to health care. The nearest hospital in Honduras is 5 hours away. The nearest one in El Salvador is 2 hours away, but it's only accessible during the dry season. And people just don't have the wherewithal to get to these places anyway. Great teaching experience, for a great learning experience, I should say, for everyone, the teachers and the learners. We're sort of all together 24/7. It's just a great educational opportunity for those there, and we hope it's a good educational opportunity for those we serve. As I mentioned, from the University of Houston, the School of Optometry students join us now mainly led with their faculty member, Dr. Lloyd Pate, who has been very faithful in going every brigade with us to do eye care. We are really looking forward to the UT Dental Branch partnering with us starting next year to do dental work there. It's been mostly done by a local dentist who's since moved to another part of the country, so they really don't have dental care right now. So in the afternoons, we have a smaller clinic, and we go out to visit these smaller villages that are in the area that we serve, to visit folks who are frail and not able to make the 3-4 hour hike to our clinic. So we sort of do house calls, which is also a real learning experience for everyone. These are folks the lady who's had a stroke. And when we're in these villages, we do a lot of public health education, etc. We have different public health projects, like this is a family garden project to try to expand the variety of vegetables and fruits in a family garden to try to overcome some of these micronutrient deficiencies. As a family medicine resident from Argentina who was doing a rotation with us, working on this family garden project. We work on sanitation issues, water resources, chlorination, and so forth. And then finally, one of the things that the Rice Group has really helped us out with is this is a typical interior of a home with a stove. There's no ventilation of the stove. People chronically inhale smoke, so there's a lot of respiratory illness. And so the Rice people, and here's Lupe and Rachel who are here today, building these appropriate technology sort of stoves that are ventilated, a Peace Corps worker helping them out. And this is the end result with a ventilated stove that obviates the need to breathe smoke all the time in your home. We're also, at the request of the community and as a cooperative with the town, trying to build a more permanent healthcare facility for the area. And we are hoping to finish this clinic by the end of 2007, although things don't move on the timeline that we anticipate always. Anyway, it's been a great blessing to be involved with this, but there are real challenges, and I just wanted to kind of go through those briefly. This is common sense stuff, but just what we've found practically in the field. So the main challenges to us, like Ann had mentioned, were economic, big-time economic challenges, educational challenges, those regarding infrastructure, those regarding medication supply, especially those regarding technology more and more, and then those of leadership and administration. The poverty is just often feels overwhelming. The folks we serve are poor, the government's poor. We think we're poor. Relatively, we're not poor, but we're always looking for money to try to support what we're doing. And there's a real feeling of helplessness. People don't know what to do to escape their poverty. It's a real problem. There's little wage earning potential for most of the people that we serve. There's the exodus to the U.S. for jobs. You don't know till you see the other end of this, but people there, it's obvious even to the outsider that this fractionates families there, and people there say that it actually is creating more dependence, that folks who are staying in country tend to just depend on the wages that their loved ones have earned in the United States, and so they're less industrious. Whether this is true or not, I don't know, but this is what's said. There's clear-cut need for new business initiatives, and this is something that we've really not gotten into yet, and we need to big time. The economics of procurement of funds and for the projects in operation, the constant battle and struggle of how to do grant writing and procure charitable contributions, corporate sponsorship, all these things that Ann had mentioned, support from the Ministry of Health and the government of Honduras. When most of us are nearly full-time clinicians, it is just a real challenge. We really need to have a fundraiser, grant writer sort of person, or else become more facile at this. But it's clearly integral to our surviving and keeping the project going. Education is part and parcel of what we do. There's an ongoing need to provide health education to individual patients and to the community. Health promotion, disease prevention is what we mostly want to be about. What people want is to have a doctor there and to be able to bring their kid to a doctor when they're sick, but we realize that so many other public health interventions would affect their lives even more positively. But we've got to kind of meet that balance and educate about that. Need to educate our own students and residents about global health issues and the need to be educated by those we serve in their circumstances and figure out ways to serve them more effectively. Challenges of infrastructure, that's a road. I don't know if you can tell that or not, but I mean, that's a road. That's what roads look like where we were. So to get a vehicle on that road, you've got to have a four-wheel drive vehicle that can deal with that. There's a lot of wear and tear. There's a lot of cost of maintenance. Fuel's way expensive in the rural areas. Electricity, we've been in this for about 5 years now. The first 2 to 3 years we had no electricity, which, is not that big of a deal, but you can't do a lot of the technology that you want to do if you don't have electricity. It is, though, an interesting challenge for Houstonian medical students to try to adapt to, so that's been kind of an adventure. But at any rate, in the last 2 years or so, we have had electricity. The town was able to get the political wherewithal to get electricity coverage to their village. There are those in the 14 villages that we serve, those that do not have electricity. There's no landline telephone. There's no internet access as a result of that. There's very little media. There's some TV and radio broadcast from El Salvador. We have been able to figure out how to get a big antenna up and get a cell phone through to El Salvador. So if a woman's in labor and is not progressing, needs a C-section, we can make an international phone call from El Salvador to the nearest village in Honduras that's got an ambulance to come over and get somebody to take them to the hospital. Anyway, crazy. And then the procurement and transport of building materials. It's hard to find building materials. It's hard to get them out to this very rural area. Medication supplies, no news there, but just the cost of medications and supplies is considerable. It's really helped by donated and reduced cost meds from the U.S., from help from groups like MAP International, from Medical Bridges here in Houston. Area hospitals and pharmacies are great about donating medicines to us and helping us out. And then we do purchase certain meds within Honduras. The logistics of getting meds there, bringing supply, each person that goes down tries to bring a bag of supplies and medications in addition to their own gear. We purchase some things in Honduras, as we talked about. But there's the ongoing problem of just how to keep up with all this and inventory meds that are available, meds that have been used, meds that are expiring, and meds needing purchase, and how to get them. With regard to technology, obviously the technology there has to be sustainable and adaptive. The circumstances, the infrastructure are very different, and the opportunities to have servicing and all are usually not available. We really have needed help, and the Beyond Traditional Borders program is helping us with lab technology. The Rice students are trying to devise a lab and a knapsack for us, so that we literally have in one knapsack where we can go out to these villages to do a basic clinical lab. Imaging, when we finish the clinic, is going to be hugely important, because how are we going to have ultrasound, radiology, et cetera, there without having servicing and with limited funds and so forth? It's something that we really ultimately are going to need help with. Again, there are experts about cervical cancer screening that you have heard from and will be hearing from. A huge problem for us. If you can imagine being a woman in a rural area, if you even have heard of a Papa Nicolau smear, but to get people, nobody has telephones, nobody has media to speak of, to get people into a central location to be able to get Pap smears, then the cytology has to be done at the teaching hospital in Tegucigalpa, 9 hours away, to get all the specimens there, to get the reports back, then to try to locate the women who have abnormal Paps, to get them back to somewhere to get a colposcopy done. It's just a nightmare. So the idea of the one-stop shopping, where you can identify cervical pathology, do a biopsy, maybe do a treatment if it looks like a treatment's needed, is something that we really need in the area. And we are excited that if those who are doing that would like for us to be part of their trials, that would be lovely. Ventilated and fuel-efficient stove, just a little plug there. Ventilated and fuel-efficient stove technology we talked about. This is another thing that the Beyond Traditional Borders is helping us with. We really appreciate that. We need to work on agricultural issues about how to do, again, an expanded variety of fruits and vegetables in a family garden in a way that is productive. And then we need help with water resources and chlorination, and just things that seem simple are not often simple in a sort of resource-restricted area like we work in. And finally, a huge problem for us is just that we go there twice a year, so there's great excitement about what we're doing while we're there. But, everybody's got a life. These folks work hard. They work hard just to maintain their family life. So when we're not there, it's sort of hard to keep things going. And the continuity issue is really huge. We are fortunate, this lady in the picture is Dr. Carol Gomez. She lives in that nice town with the paved road, Colomancagua. And she and her husband, who's a pastor, are getting involved with us more and are sort of going to be our continuity people. And she started to go to this little village now about 2 or 3 half days a week to see patients. And we're hoping that she'll be the first doctor in this clinic when that's finished. Empowerment of local people is just hugely important and a constant challenge for us. Local leadership, and then ways to get involved and be in collaboration with the Ministry of Health are challenging, because the Ministry of Health officials change about every 2 years. So as soon as you get a program planned, about the time you get to it, the leadership is changing. So it's a real problem. Anyway, just a few of the challenges that we face. I appreciate your attention.
Well, I'm Dr. Fallon. I see all my staff cringing because we'd love to help you with the cervix. But yesterday I was panicking about following Mark Klein. And now I've got to follow you. And now I'm really worried. I think the area of medical diffusion is astonishingly complex, and none of us quite understand why things don't happen much faster than they should. Our project is really about trying to save women's lives. And we started, Rebecca and I, about 16 years ago, working on automatic technologies for diagnosing cervical cancer. And the cervix, like the mouth, is a nice area because you can see it easily. We ended up teaming up with people in British Columbia who were looking at the lung, and that is a really hard area. And together, we've been able to make a lot of progress sort of in both. Poor Mr. McKelvey, just as he said, he came to MD Anderson, he said, I want to work on malaria, and somebody steered him toward me. And I said, we're going to do an on-the-ground project in Nigeria, and we already have identified collaborators. And he said, we don't do cervical cancer. I said, but you need to, Mr. McKelvey. And so he gave us some great startup funds, and then Mr. Pickens, who funds my chair, matched, and we've had quite a bit of other help from FedEx, as I'll explain as I go on. So I think the real message that I have felt throughout the conference, and that I'd like to push forward at this time, is that all these incremental improvements happen through collaborations and relationships and people. And that's really how it works. You've got to get the doers together, and they'll find the resources and they'll see it. Yes, it will take 10 times longer than they think, and it will be much harder to do than they know. But it's all about the people. And the way this project has worked is through my incredible staff and Rebecca's incredible students. And that's really the story behind it, because you could never do what we've done. Now we know Isaac's incredible staff, and all the things we've done as three. So we picked cervical cancer because I'm a gynecologic oncologist, and it's also a disease that affects women that is just tragic, ending their lives in their 20s and 30s, taking them away from their children, taking them out of the workforce. And I learned about it firsthand when I was in the Bronx being a public health service doctor, and saw that the women from the impoverished areas in the area I was serving would literally come in at end stage and die, and I would send them to Einstein and they'd get radiated, but they'd still die in a few months. And so it was so tragic. And then when I came to MD Anderson, fortunately, then it was still a public institution that took all kinds of patients, and I saw lots and lots of cervical cancer from all over the state of Texas and from all over the world. And then when MD Anderson went private, we started a service at LBJ that has been enormously successful. And we're able to get patients into treatment at MD Anderson within 3 days, which is a lot better than the people on managed care or private insurance, I hate to say. And as many authors and speakers have shown, I mean, cervical cancer demographics, the incidence and mortality are very linked to poverty. And this thing is hard to use. This is the incidence, so the new cases. These are the mortality. And while it is becoming an uncommon disease in our own country, we have maybe 13 or 14,000 new cases per year, and Canada has roughly the same number based on their population. There are still 4,000 deaths, even now, when we've had the Papa-Nicolau smear since 1943. This is a graph from British Columbia. So on the abscissa, we have the years. They started their screening program in 1955, and it's a fabulous program where they track immigration, emigration. And the Canadians do things so well, and they have a socialized medicine, so everybody comes in for their visits, and it's much more organized than our own country. But here the incidence was about 35 per 100,000, and it fell to about 7 per 100,000, while the mortality on this ordinate was about 7 per 100,000 and has now fallen to about 2 per 100,000. And we and they are worried about this. We have not been able to make a dent for 20 years. And so who are we missing and why? And how can we appeal to them in a way or with technologies that make the diagnosis earlier? The tools that we currently have are the Pap smear, which has been widely studied in the last 10 years, but is thought to have a sensitivity and specificity of 60-60. I think it's more 50-90, but that's still in the same kind of ratio of success. And colposcopy, which is greatly overcalls so that you make the diagnosis, but it has low specificity, so you're always doing a lot of extra biopsies. And the extra biopsies done for atypical smears in the U.S. cost the U.S. $6 billion annually. So in the West, we are wasting money. In the East, there are no resources. And as Anne showed, it's a logical model which takes place over years. Unfortunately, women don't start to have any symptoms of bleeding until they already have early invasive cancers that are outgrowing their blood supply or exophytic lesions. So many, many years ago, another Rebecca thing, she gave a conference, and we invited Ben Littenberg, and he was interested in tech assessment. And 6 months later, we wrote the PO1, which was all about tech assessment. So we tried from the very beginning to study the problem from both situations, from the developed world and from the developing world. And it was wonderful to have federal funding to do this because we've always been able to look at how cheaply we can do it. And we always thought if it gets licensed, the companies will figure out how expensively they can do it. We tried to be careful about patenting. This is us writing our renewal, the renewal, I guess, of the PO1 at Rebecca's house. And it's a massive group. And at this point in time, we all speak a different language. And there's no way we can write anything without being with each other. So let those who ask us be warned. Now, Isaac, at the University College Hospital in Ibadan, which is one of the oldest medical schools in Africa. When we met Isaac, it was an instant friendship, collaboration. We saw that together we would be doing wonderful things. It's wonderful to be at Anderson, but we have also lots of collaborators at the British Columbia Cancer Center, and they have also gone on our trips, and they provide a wealth of cancer experts as well. I noticed that I made Dr. Cordham the future director of the Global Health Institute at Rice, but I also wanted to start a medical school, so get that on the list, would you? Now, Rebecca and I actually we went to Exxon with a proposal to go to Nigeria. And, you know, when we went to the WHO, people go, why Nigeria? I said, why Nigeria? Because a fourth of all Africans live there. And they use a lot of technologies, and they don't care if they have telephone lines. And when we met Isaac, he had 5 cell phones when he first came to visit us. I said, what are you doing with 5 cell phones? You know, a tower goes down, you know. And then I said, I wanted to fax him. So I said, don't fax me, scan and use the internet. What are you talking about? And I said, whoa. You know, so this idea that we would have technologies that would skip steps, they liked. And that it was not a bad idea. Moreover, we had tested them in the US and Canada for 20 years, some of them for 20 years, like the CytoSavant. So they were fully tested, fully vetted in our own environment before we ever thought of taking them to Africa. And I'll get into a little bit about the ethics in a moment. But anyway, the Canadians had developed, and we have helped them further develop, a system that automatically reads the pap smear. It's looking at ploidy. Ploidy is really looking at the amount of DNA in the cell, and cells that are really screwed up look different, as you can see. And there is normal cell cycling, so as cells are doubling, they do look a little different. But it's a very sophisticated system at this point in time, and it can pick out when the DNA is over about this index of 2.2, 2.3. And so we get a quantitative reading, which happens automatically, reproducibly, and overnight. The most recent addition to our PO1 is that the scientist working on this has developed a fast stain, and we are now going to be able to do a PAP and give a woman the results in 4 hours. Don't hold me to that yet. In your setting, we ought to go try it there. They took the system to China. They've done 3 million pap smears for $3 a piece. These are some of the results from an interim analysis just to show the ploidy works as well as, if not better, than pap readings by the British Columbia cytopathologists and the MD Anderson cytopathologists against, read 3 times, by the way, each, against pathology biopsies that have been read 4 to 6 times. And so, this is a very interesting technology. Why hasn't it taken off in the U.S.? I don't know. So they now have the price down to $3 a slide by making a less expensive microscope. And it takes a tech, and we're quite excited about it. As part of the program project, we also took 4,800 biopsies, and we had those read by 4 to 6 experts. So they scanned them in, and they made a database of all of our biopsies. And it works on the basis of hematoxylin and eosin, the common stain here. We have a database of the Fulgen stain, which is quantitative. But this can make our collaborator, Dr. Okolo, an expert in cervical cancer overnight. And this is one of the other interventions we're doing very soon. We may have to buy him a system, but we will. And we're going to allow him to use it and the other pathologists at the 6 sites. So one of the other things we've been working on is quantifying pathology. And it's been very reproducible, very productive. And we're in the process now of analyzing our data and comparing it to the clinical, and comparing it to our fluorescent measurements. And there's a lot of, actually not so complicated math. The cellular relationships here are not even, you can see that. And so there are not only nuclear features, but architectural features that are very interesting. So we have a huge database of these, and these are also being shared with our collaborators. So in the beginning, Isaac said yesterday, they brought something really complicated. And we did. We brought what we thought would be a good thing. And, we said, we want to do this with you. We'll just show you what we have. And Isaac said, okay, bring it on, come to clinic. And so we had a device that images the entire cervix at once, using a combination of white and UV light. And we were able to get a pretty good correlation with it and the pathologic map. And by then we'd done 70 patients in the States, and the technology is very much like another technology we're using, which we had studied on 1,800 patients in the US and Canada. So we felt pretty good about it. But when we got to clinic this is Darren Robler, our poster child for the project, actually, one of Rebecca's students and one of the med to grad students. It looked pretty complicated because now we were worried about electricity. And this was actually our second version of it, and Isaac said, it's still no good. So that launched a new project where we've been using light. What we figured out in teaching is that probably the vasculature is the most important thing in sophisticated diagnosis of neoplasms. So as Rebecca and Callum got to thinking about it, they said, well, why don't we use cross-polarized light? And they were able to show, indeed, that it's much easier to see the vessels with cross-polarization, and that when you add a green filter, they're even more apparent. And the important thing about this, no, I'm not stealing anything in the mouth, that's just where they started, but is that it makes it much, much easier to recognize these areas of abnormal vasculature, and it would be better seen if it were a little darker in here. But anyway, we are able to then see the normal vasculature of the cervix, and it's that disruption of normal that allows you to be a very sophisticated colposcopist. So we're quite excited. This is a camera, battery-powered camera. So when we do our next study, we will do it with that. But the real effort, what Isaac wanted, and what he wanted for his country, and what we wanted for him and his country, was to start an effort to screen for cervical cancer with whatever tools we had. And we all know the PAP is a pretty good tool, and the World Health Organization has advanced visual inspection with acetic acid, which is just throwing vinegar on the cervix, as another tool. So Isaac came to a conference with us. That was before we met ExxonMobil, and we were hoping to endear them to us, but we hadn't yet. And he went back and formed his teams. He told us when we first got there that there were 6 teams, and that they were from the north, the southeast, the southwest, and those represented 3 important areas of Nigeria, both ethnically and religiously. So we met with the entire department, and we told them a little bit about what we did. They told us what they did. They told us what their needs were in Ibadan. And we went out to see their magnificent hospital, a 900-bed hospital. So Methodist is, I think, an 876-bed hospital. I think Herman is probably 600 beds. We don't have many 900-bed hospitals in our country, and this is a phenomenally big hospital. And they're doing a lot of very sophisticated care there. We met with the dean. We saw the patients at the pharmacy. This was a little stand, but we loved seeing the women going in and having something to eat during the middle of the day. This was the head of radiotherapy. This is the radiotherapy machine there that's functioning. The other one was not functioning, and that was because there's a piece missing, and the device is 20 years old, and it was hard to get. This gentleman, Mr. Adewale, is an engineer without a college education who fixes everything in the hospital, including the radiotherapy devices and all the imaging devices and all the laboratory devices. One guy for a 900-bed hospital. I mean, we gave him a computer, and it was he needed a little instruction to start using it. He was a little bit afraid of it, but what an amazing guy. And to think that he does all that without ever consulting the computer. I mean, it's probably unimaginable to the students. We submitted the trial in Ibadan to the IRB, and Isaac had built up a pretty sophisticated infrastructure. He has PEPFAR funding. So they have a good IRB, and the IRB decided this was of low risk and we could try it together. And the day that we were there, we got to know everyone quite well, but also this is a leap that our African collaborators did. So, you know, these wonderful attendings took about 10 minutes to figure out how to do something that we spend hours teaching everybody here. And then we saw 100 patients. They came because they heard that we were working together, and also because of the fabulous reputation of the University College Hospital. And Isaac had the idea to give the women buckets that said, or pails, I'm not sure, but they said Operation Stop Cervical Cancer in English and then in Yoruban. And the women were just thrilled to have these. And later on during our stay, when I saw people carrying water, washing clothes in them, and I realized what a very, very useful gift it was. And Exxon also really loved this. They wanted it to have ExxonMobil on it, and I guess next round we'll do that. So this is the problem. They said, okay, we're going to give you a seed grant, Fallen. You know, it's going to be less than $100 or $100,000, and we're going to see if you're going to make this project work. So the same week that we were there doing the study, we also held this conference with the leaders from all the 6 geopolitical regions. They brought their teams of bioengineers, nurses, administrators, and physicians. And we held a wonderful conference. And at the conference, we mixed everybody up. And we got a little bit of press. There's Isaac on the television. And we decided that we would also go to the WHO to see if there was anything there to leverage. And I guess the story of the WHO is they really have very little money. They do have a number of wonderful publications, and we bought from them and copied what we could copy, but we bought principally the publications they have that are relative to cervical cancer. And they do have one really incredible manual that sort of goes from A to Z, and we used that as a big teaching tool. So the sites produced a list of what they really needed. And the thing about it was it involved a lot of trust, because one site didn't want another site necessarily to know that they had certain things. And it was just true. Some places had been university hospitals longer than others, and some places had been in areas where governors had gotten them more supplies. So their needs were different. But the biggest consensus among the needs were colposcopes, screening utensils, and electrosurgical machines to do the leaps, and then training. And so we said, okay, next visit. And my staff proceeded to ship 4 tons of equipment, and FedEx comped the shipping and helped us with the issues all the way through the U.S., all the way through Nigeria to Isaac's door. He has a FedEx office at the base of the medical school, and it was a phenomenal help, needless to say. When it got there, then we had to sort it out again, and this is Dr. Miller, my colleague in gyn oncology from British Columbia. And then we had to unpackage things because we were going to use some of them during our training sessions. And we made sure that every site got the same amount. And then here is, we have a Stop Cervical Cancer banner there from Exxon, but the sites were so excited when they packed up their things and took them. And so all of the ExxonMobil money is in Africa. This represents about $450,000 worth of stuff. And that's more than I've been given. And so I hope Mr. McKelvey comes through with longer term plans, because right now I'm in overdraft in all the accounts. But as I keep saying, Mr. McKelvey, you know, we need to keep the momentum going, sir. The things that we had to set up lectures on were maintenance of equipment as well, use of the computer. People didn't have computers, and we took over enough laptops so that nurses, we knew doctors would have them, we knew nurses wouldn't, we knew data managers wouldn't. So we trained the data managers, we trained the doctors, we trained the nurses, we trained the bioengineers in maintenance and repair, and we talked about what we need to do next. And we had about 70 people there for the lectures. We divided people into discussion groups, and we used some of the American leadership training that we've been very fortunate to have, in which we separated people by different numbers and letters so that they were forced to mix up with each other. And that broke down the barriers of the doctor versus all the other members. And it was very, very effective in getting the communication going. And then we actually did some pre and post testing, and we tried to write a little paper about that. And, you know, the manual that the WHO puts out in this area is an excellent, even outstanding instrument. And so people, of course, improved across the board. We had a large number of nurses there. My nurses went over and they lectured on all aspects of nursing, all the way up to performing the leaps, as our nurse practitioners do at MD Anderson. So we empowered the nurses to do cryosurgery and leaps themselves. And in Nigeria, they are midwives. They know a tremendous amount about the anatomy. They don't focus on the inpatient side. If they're going to do this, they focus on deliveries, outpatient gyn, and so they're very facile. And I mean, Dr. Adewale's pap smear nurse could probably do 50 pap smears in a morning, and nobody would bat an eyelash. And now she can also do cryosurgery and LEAP, and we started screening for hypertension and doing breast exams, because those were things that had gotten ignored in the past. So it was a real lesson to use the blood pressure cuff, you know, and the thing is, it's a prevalent disease there. You know, again, it's a chronic disease. It's less important than AIDS and malaria, but, you know, as we fix things, we want to fix them well, so we decided to tackle that as well. There's Trey, and he lost his suitcase, and so he has like 9 Nigerian outfits. He looked so handsome in them that poor Dr. Adewale felt that he had to get each one of us an outfit. And I should have worn mine today. I don't know. I was too shy. I know I won't look as good as he does. But anyway, Trey was so handsome in it, we all realized what beautiful clothes the Nigerians wear. And the other thing Trey said is, "Oh, this is so cool." And we were like, aha, because none of us had on cool clothes. So we were very enchanted by the clothing. I did several practicums. I did one with the doctors that lasted 4 or 5 hours in the evening, and we set up with beef tongues. And then my nurse practitioners and nurses did another one with the nurses. So the nurses actually participated in both, and that was really empowering to have them on their own. Some of the nurses had really good eye-hand coordination, and of course learned the procedure in maybe 10 leaps, and then I had one doctor that had to do 150. I'll tell you, that took great patience. But you know, it's just, what are people's skills? And we're not very good at assessing that in medicine. So Trey and the data manager in Nigeria have set up a working communication, because my philosophy is that nothing works unless you meet weekly and you've got more than 5 people working on it. So we've tried once, and we're going to resume in 3 to 4 weeks. We did take blocks out of Nigeria to the WHO. This was pre any regulation about tissue. And that's because they'd done a prevalent study in Nigeria. They knew there were different types than are in the vaccine, and they wanted to see if the invasive cancers indeed were coming from these other oncogenic types or still coming from 1618. So, when the vaccine came out, we were all worried about the developing world because the types that are present in the rest of the developing world are not in this vaccine, which costs $360 and has to be given in 3 doses. And yes, PATH did put it in syringes that can't be reused, but, at that price, it would cost $14 billion to vaccinate young women and young men in Nigeria. Martial Guillot, who's been working with us for 12 years on the expansion of the technology for the quantitative cytology. We have 2 devices in place there, renovated laboratory space. Dr. Okolo came over and spent 3 weeks with us, 3 weeks with them. And his lab tech has most recently been trained, and now we're going to launch the lab in May. So that's very exciting. We were going to beg the health minister at this meeting to subsidize the pap smear, and we really did. We went all the way to the top. We called him and nearly called the president over it, but he has diminished the cost of the the pap smear at 2 sites for us. And then we are putting together a comprehensive radiotherapy plan, because currently only 3 of the 6 sites have radiotherapy facilities, which means if a site diagnoses an invasive cancer, they have to be transported. And we made sure that transportation is in place, but that's really a problem if we're going to gear up and take care of a lot of cancers. So we have contracted with the IARC and the WHO to set up a population-based cancer registry in August. It's planned, except the dates will do it. We plan also to make site visits to our 6 sites. We have a barrier study that's being financed through the ExxonMobil funds, but is led by Demiji Oladipo, who's a PhD from UNC, very, very experienced guy. And so we're going to launch it at the 6 sites. It'll be a very novel kind of study, and I think eventually we'll get NIH funding for it. And then we're hoping to do a big launch nationwide after our launch in the States, but hopefully in 2009. And that may be 2010, but I'm hoping for 2009. So we thought about, when we were trying to arrange the course, we tried to bring people in the diagnostic imaging area and the radiotherapy area. It was very hard to get people to go, but after we were there, we decided it would be much better to bring the Nigerian doctors here. And between this experience we have at MD Anderson and at the British Columbia Cancer Center, it's very easy to train people. Are we going to take them to see the proton device at MD Anderson? No. I mean, we don't even know if the proton device works yet, right? Why bother? But we have identified a few suppliers of cobalt machines that exist in India and Canada, and we will work with them to make a plan to buy them. Now, can we do that on the Exxon money? No. We're going to have to figure out a different way. But now that the government is in good shape, because they have a surplus, hopefully they will invest in this part of health. So since the beginning of the program, from January to July, without any equipment, just with having done a needs assessment, between the 6 sites or among the 6 sites, they did 500 pap smears and identified 50 high grades. Since then, since our trip and the giving of equipment, 5,000 pap smears, 200 high grades, and 2 more cancers. So altogether, we've saved a couple lives and treated a number of high-grade lesions. And that's just the start. So I think, again, perhaps there are enormous obstacles. Of course, you want to do everything ethically. That's the most important thing to ever consider. And it's been a great blessing to be able to include the students and to have such a remarkable collaborator. But as you can see, we've had a lot of fun. And we took that picture for Exxon. I think what we've learned, or at least I have learned, is that we have a lot of experience here and in Canada, and some good, some bad. We have successes and we have failures, particularly in cervical cancer over the last 40 years. So we have that to share. But what I've learned about is the wisdom, patience, need for simplicity, and a different way of seeing things. So it's Isaac that came up with the idea of not taking the big device. He said, it's got to be simpler. It's got to be something you can carry. And when we brought that message home, we started working on that. And so I think it's really an underestimation of your African partners to think that they don't know what the solutions are. I think they know what the solutions are. And I think it's only in working with them that we will get there. They have much, much to teach us.
Thank you very much. We are running a bit behind schedule, and so I'm going to suggest that we postpone the discussion till our lunch. And what I'd like to do is move to our closing remarks, which will be provided by Professor Vivian Ho, who is a fellow in the Baker Institute and holds a chair in health economics here. She has joint appointments in medicine at Baylor and in the Department of Economics at Rice. So welcome, Dr. Ho.
I'm privileged to be able to close this wonderful event, and I particularly appreciate those of you who have stayed here for both days. We've had outstanding presentations that we've heard by scientists, ethicists, economists, business leaders, and policymakers. These individuals have been at the forefront of efforts to achieve the 8 prescribed Millennium Goals, which aim to reduce poverty around the world and hopefully eliminate extreme poverty. It's been a rewarding learning experience, and I think many of the participants are going to be leaving this conference with a new understanding of the impact of biomedical research and new technology and how they influence global health issues. Part of my privilege as the closing speaker is to thank the organizers of this particular event. Dr. Rebecca Richards-Quarterman and her staff at the Beyond Translational Borders program, including Yvette Mirabal, envisioned this event as well as personally contacted the speakers to bring them here in the past few days. And we should also thank their Baker Institute counterpart, Kirsten Matthews, who is the Science and Technology Program Manager in the Baker Institute event staff. As well, including Melissa Llewellyn, who's been behind the scenes. Everyone has worked extremely hard in these past few months, and the results are evident in the event we participated in these last 2 days. In addition, I would be remiss for not mentioning the Howard Hughes Medical Institution and their support of not only this event, but the Beyond Translational Borders program. The Howard Hughes Medical Institute has a reputation for excellence in innovative thinking, particularly with respect to Beyond Translational Borders. Now, some of you sitting in within the Baker Institute may be wondering what else goes on here besides us hosting events such as this. We're just briefly, the Baker Institute is a strong track record within Rice University of achievement based on its work with the Rice faculty and the Institute's endowed fellows and scholars. The goal is to bridge the gap between theory and practice of public policy, and we do this by collaborating with experts from academia, like we've been doing for this conference, as well as government, the media, business, and non-governmental and private organizations. So beyond our collaboration with Beyond Translational Borders, the Baker Institute has several initiatives addressing issues of health policy and or policy in developing countries. These include the Global Issues Series, the Health Economics Program, and the Science and Technology Program. And I'd encourage you to perhaps come back and hear about some of these other programs. The Global Issues Series was established in honor of the former Secretary of Commerce, Robert A. Mosbacher Sr., and the series will host academics, trade policy experts, policymakers, and major stakeholders from the private sector to engage in workshops, conferences, and lectures on program-relevant topics. The recently created program hopes to hold events at the Baker Institute nationally and abroad. The Health Economics Program is the program that I'm in charge of here at the Baker Institute, and the mission of the program is to study the way in which economic incentives and government policies influence the quality and cost of health care. And our guiding philosophy is that society can deliver higher quality health care and at reasonable costs. We're a small but growing program, and you can follow our progress on our website. Our research this year has been featured nationally by the New York Times as well as locally by the Houston Business Journal. We also have a science and technology program which has as a component looking at global health issues, and it has been a co-sponsor of today's event. The program is led by Neil Lane and Kirsten Matthews, who's a physicist and a molecular biologist, and they look at issues such as climate change, non-proliferation of nuclear weapons, stem cell research, and genetic testing. And one of the larger projects initiated in the last few years is their program on stem cell policy, which you may have attended as well. The International Stem Cell Program was recently endowed by the state of Qatar and has conducted a series of conferences in Houston and Washington, D.C. titled Stem Cells, Saving Lives or Crossing Lines. And they've looked at everything from moral and ethical concerns to regulation or lack of regulation in the United States on this issue, the consequences of defederalized research funding, and the impact of U.S. policy on an international collaboration. With the endowment from the state of Qatar, the program is going to expand its research from domestic policies to international policies, regulations, and cultures which impact embryonic research. In addition, at the Baker Institute, we have smaller projects which involve collaboration between programs, in particular the Health Economics and the Science and Technology Policy Program. For example, Dr. Matthews is leading a study to determine the impact that foundations interested in global health have on biomedical research in the United States. Now, if you've heard over the past few days, developing countries are starting to focus efforts on developed countries are starting to focus efforts on the poorest countries in the world. And many of these efforts are being led by governments and their aid programs, but the majority is being pushed by non-governmental organizations, or NGOs. With only 10% of research dollars in rich countries being directed towards diseases such as malaria, tuberculosis, and AIDS, which are infecting and killing millions in the developing world, the role of NGOs is increasingly to encourage and support efforts by government. It's been encouraging to see all the scientists that we've had and hear about innovative research these past few days. We've also noted, though, there is going to be a lengthy road ahead. Scientific and medical innovations will lead to major improvements in the affected regions that we've looked at. And as policy researchers, we at the Baker Institute also believe that carefully planned policy interventions at all levels are crucial to sustaining this effort. So we're a proud co-sponsor of this event, and we look forward to continuing work in this area in the future. And with that, we'll just close the event and move on to lunch and hopefully some future discussions and more progress in the future. Thank you.